So it's my great pleasure to discuss the medical treatment of soft tissue sarcoma and GIST. We're going to start with the soft tissue sarcomas, and this is just a little bit of a background, so I apologize if some of the concept will be repeated. So as you all know, soft tissue sarcomas are rare cancers. They represent about 1% of all adult cancers, but they are 15% of cancers in the pediatric age. And local recurrence after surgery is quite common, and metastatic disease is also quite common in more than 40–50% of cases. And we already had a preview of one of the common themes in treating soft tissue sarcomas, which is the huge heterogeneity of this disease type, both in terms of location and in terms of clinical presentation. And this is because of the huge number of subtypes that we have at the pathological levels. And the most common ones are liposarcoma, leiomyosarcoma, undifferentiated polymorphic sarcoma, and GIST. But we also have a number of ultra-rare histologies, which are really even more difficult to treat because of the low number of cases. So when we think about chemotherapy in soft tissue sarcomas, I think that similar to what already mentioned for radiotherapy, we really need to think that because we have so many histologies, they don't sit all in the same place. We have some histologies which are more chemosensitive, some that have intermediate chemosensitivity, and some that we know they are basically completely chemoresistant. So for example, among the most chemosensitive histologies, we have all the tumors that belong to the small round cell family. For example, rhabdomyosarcoma, Ewing sarcoma, desmoplastic small round cell tumor. And we have then intermediate sensitivity like UPS, leiomyosarcoma, DDLPS. And then we have tumors, soft tissue sarcomas, which are relatively chemoresistant, like solitary fibrous tumor, desmoplastic DFSP, and alveolar soft pulse sarcoma. And based on the chemosensitivity, then the approach that we have is different. So for the more chemosensitive tumors, we often consider polychemotherapy regimens with 2, 3, 4 drugs. And this is the standard of care in any setting, in the localized disease and in the advanced disease. For tumors with intermediate chemosensitivity, we often use chemotherapy in the advanced setting, but the use of chemotherapy in the neoadjuvant or adjuvant setting is a little bit more complex and debated. And we oftentimes use single-agent chemotherapy as our first line of treatment when the main goal of our treatment is overall survival. And we reserve doublet chemotherapy to those cases where having tumor shrinkage, so to achieve objective response rate, is our main goal. And for sarcomas that are not particularly chemosensitive, sometimes we can consider alternative treatment options. For example, tyrosine kinase inhibitors or immunotherapy, as in the case of the alveolar soft pulse sarcoma. And at the Marsden, we often consider early referral to phase 1 as well, because when you don't have active treatments, at least this could be a good avenue to have more opportunities. So just very briefly, in terms of localized setting, as I said, chemosensitive histologies, we often use chemotherapy both in the neoadjuvant and adjuvant setting. This is the case for Ewing sarcoma, desmoplastic small round cell tumor, rhabdo. And these are regimens with several combinations of chemotherapy. So for Ewing's, we often use a combination of alternating combinations of 3 chemotherapies, VDC, with increasing doxorubicin cyclophosphamide, alternating with ifosfamide etoposide in the preoperative setting. Then we have the final local treatment, which can be surgery or radiotherapy, and this is followed then by consolidation chemotherapy. And this regimen is the one that showed the best results in a randomized phase 3 trial, and is considered standard of care. As you can imagine, it is a quite toxic regimen, and it's quite challenging to give this chemotherapy. Patients oftentimes require admissions to treat because of the side effects. But for these particularly chemosensitive histologies, especially in a curative setting, we have to do all we can and our best to try to deliver as much chemotherapy as possible. And another example of this is rhabdomyosarcoma that, based on the risk group, can be treated with a combination of IVA, which is ifosfamide, vincristine, and actinomycin, plus or minus doxorubicin as well. Histologies with the intermediate chemosensitivity, as I was mentioning, in the localized setting, the use of neoadjuvant or adjuvant chemotherapy is a little bit more debated, and we'll briefly go on the details. Doxorubicin plus ifosfamide is considered the standard of care for most histological subtypes. In some institutions, including ours, we're starting to use the combination of doxorubicin plus dacarbazine specifically for leiomyosarcoma. This is based on data from the metastatic setting, which I will show later on. And why do we say this debated? Because we know that the chemotherapy is beneficial only to a limited subset of patients, which are patients at a very high risk of relapse. Now, defining this high risk of relapse can be quite difficult because there are different tools, nomograms that have been developed over the course of the years. And at the beginning, only size mattered, then we included the histology, the grade. So even the definition of high risk has changed over time. And there are, as I said, histological subtypes were more likely to benefit from chemotherapy. We know that high-grade tumors are more likely to benefit from adjuvant and neoadjuvant chemotherapy when the tumors are particularly big or when there is inadequate surgery. And one of the tools that's been validated in many series and is sometimes used and that you can easily use from your phone is the Circulator app. This is a prognostic nomogram that has been developed by the group in Milan and validated on a number of cohorts, which takes into account the factors, the variables that I just mentioned, and it can give you a rough prediction of what is the risk for your patient to develop a metastatic disease and to die from the cancer. It's important to say that this tool has been developed as a prognostic algorithm, not as an algorithm predictive to select the patients that could benefit from chemotherapy. But now it's being used, and there are some studies which I'll show which show that this algorithm could potentially be also helpful in selecting the patients that might benefit from chemotherapy. One of the first and most important studies on adjuvant chemotherapy was published by Wall and on the Lancet, and in this case you can see that control versus chemotherapy, there is virtually no difference in terms of survival outcomes, and this is why the use of chemotherapy is debated, because at the beginning in this initial study, the inclusion criteria were quite wide. Any grade 2 or grade 3 sarcoma was resected, any histology, any anatomical site with complete or marginal excision. And based on subsequent analysis, we realized that the population that was included in this trial was not necessarily the one that could benefit from chemotherapy the most, because there were also histological subtypes which we now know are not chemosensitive. Central pathology showed that a review showed that about 60% of the patients had grade 1 tumors. The largest tumor dimension was less than 5 centimeters in about 24% of the patients. And the ifosfamide dose that was selected for this trial, which was 5 milligrams per meter square, is actually lower compared to the dose that is currently recommended. So for all these reasons, this trial, though negative, was considered to be not really informative rather than negative, strictly speaking, because the patients that were included were not the one that we now consider at high risk. And the Circulator tool has been used to reanalyze in a post-hoc analysis the results of this trial. And what's been shown, and this is only for extremity and trunk wall, importantly, and what's been shown is that if you so if you look at the two blue curves, these are patients that, based on the Circulator, had a high probability of survival. So their disease was, we can say, less aggressive. And in this subgroup of patients, having or not having chemotherapy doesn't lead to any change in outcomes. But if you look at the patient population with a low probability of survival, so patients that had a more aggressive disease, in the dotted line, you see the results of the subset of patients that received chemotherapy, whereas in the continuous line, the one that only received observation. And this difference is quite significant in terms of of gap that we can see in overall survival. So based on this post-hoc analysis, some centers and some nations now are basically recommending the use of neoadjuvant or adjuvant chemotherapy in these patients at high risk. But in other countries and in other centers, this is not done because this is a post-hoc analysis of a negative phase 3 trial. So that's why there is a little bit of differences in the use of neoadjuvant and adjuvant chemotherapy. Now, a subsequent trial have been run, and this is the most important, on the use of neoadjuvant chemotherapy in selected histologies with, in this case, 5 histologies that were selected, only grade 3 and only extremities and trunk wall and largest dimension more than 5 centimeter. And in this case, the standard of care, which is epirubicin or doxorubicin plus ifosfamide, was compared with histotype-driven chemotherapies to see whether we should still use doxorubicin-based chemotherapy for all our patients, or if we could identify regimens which are more effective or more tolerated. And this trial was not run again in all across Europe. For example, it didn't run in the UK because in the UK, considering the use of neoadjuvant chemotherapy as a standard is not something that we do. What this result has shown is that the standard chemotherapy with anthracycline and ifosfamide is actually better than the use of the histotype-tailored chemotherapy. Now, if you, a way in which this study has been interpreted is that if we assume that receiving any kind of chemotherapy is not worse than giving placebo or just observing, then you can assume that patient that, in the worst case scenario, patient receiving observation will go similarly to the histotype-tailored chemotherapy. So indirectly, you're confirming the superiority of the standard chemotherapy. This was a post-hoc interpretation of the study because the design was to show superiority of the histotype over the anthracycline. The only histology where the histotype-tailored chemotherapy was shown to be non-inferior to the doxorubicin is in myxoid liposarcoma, where trabectedin has the same efficacy of anthracycline-based chemotherapy. This has been published in January, so a few weeks ago. It may change our practice, we'll see. And everything that I just mentioned is for the limbs and trunk wall sarcomas. In the retroperitoneum, the use of the neoadjuvant chemotherapy is something that is being currently tested in a clinical trial, comparing in liposarcoma and leiomyosarcoma, comparing surgery versus 3 cycles of neoadjuvant chemotherapy with doxyphos for liposarcoma and doxdacarbazine in leiomyosarcoma. The recruitment of this trial has not been great because, as you can imagine, these patients often present with tumors who are 20, 30 centimeters big, and they're quite symptomatic. So, and they're also deconditioned by these very large tumors. So giving chemotherapy in that setting has been proven to be a little bit more difficult compared to the limb setting. So as take-home message, the standard of care for selected chemosensitive histologies is polychemotherapy. The use of chemotherapy is highly debated in other histologies, and we use the standard for most histologies is doxorubicin or epirubicin plus ifosfamide. And there are some important considerations when discussing patients in MDT. The likely presence of microscopic residual disease, for example, in Hoops operation, on large and high-grade tumors at sites where wide excision is impossible, for example, head and neck, is not only a good reason to offer radiotherapy, but something that we consider also for adjuvant chemotherapy. And this is especially the case when we have chemosensitive tumors, for example, the one that I mentioned before, or synovial sarcoma. When we move to the advanced setting, we have to consider a few things. One is the goal of the treatment, and then we can discuss the type of chemotherapy that we can offer in the first line and further lines, and then the exceptions and emerging treatments. In terms of goal, it's important to think what is our the main reason why we're giving chemotherapy. Do we want to help with symptoms? Do we want to increase the survival of our patients? Because for symptom control, we want to give regimens where we maximize the objective response and the tumor shrinkage. If the patient is not particularly symptomatic, then we can opt for other chemotherapies, even though we must say that there is overall a limited evidence that chemotherapy can significantly prolong life in sarcomas. We have always to consider the toxicity to benefit ratio. In some soft tissue sarcoma patients with low burden of disease or biologically indolent disease, they can be asymptomatic without treatment for long periods of time. In that case, chemotherapy can be delayed. We have patients, for example, with resected leiomyosarcoma and very small lung mets that we keep under surveillance for a very long time, or we offer localized treatments to the progressive sites, like radiotherapy or ablation, and we keep chemotherapy in reserve only when we see multifocal, more rapid disease progression. In a way, we're trying to increase not only the duration of life, but also the time that the patient can enjoy the best quality of life. And being off chemotherapy is part of that reasoning that we have to do in terms of quality of life. And then, of course, there is patient choice involved. There are some patients who they value more the idea of trying and fighting the cancer, and you can be a little bit more aggressive in the treatment. There are patients that actually give priority to quality of life, and they're not so much interested in duration. And this, of course, changes with the background, but also with the age. For example, you have elderly patients that they prefer to maximize quality, whereas younger patients, they would like to maximize quantity as well. In terms of studies, doxorubicin plus ifosfamide versus doxorubicin by Ian Yadson as a first author is the most important study. And we can see on the Kaplan-Meier curves that in terms of overall survival, there is a difference which is, however, not statistically significant, and it's a difference of less than 2 months. In terms of progression-free survival, the difference is more significant, both in terms of difference of medians and also in terms of statistical difference. But if we look at the response rate, doxorubicin as a single agent has a partial response of 13%. Considering that this is one of our standard first line, you can see that it's really, really poor. And in the doublet, we have a response rate of 25%, so almost doubled. And this is the reason why we often consider doublet chemotherapy over single agent in patients who are fit, young, and symptomatic, and they need shrinkage, particularly if they have chemosensitive subtypes. But there is a cost, of course. And if we look at the febrile neutropenia, doxorubicin only has 13%, whereas in the doxyphos, it was 46%. So, of course, the toxicities are much higher. The renal toxicity, the neurotoxicity of the combination with ifosfamide is much higher. So we always have to balance the benefit and the risks. As I mentioned, for leiomyosarcoma, there is evidence that ifosfamide is not particularly effective, whereas dacarbazine has higher efficacy. And this is a retrospective analysis of the combination of doxorubicin plus dacarbazine versus doxorubicin alone or doxyphos. And doxorubicin plus dacarbazine seems to be a little bit better in terms of efficacy, but if for sure is much better tolerated than doxyphosphomide. So at our institution, we often select dox-dacarbazine as the combination for leiomyosarcoma requiring doublet. Second and further lines are a little bit more complicated. It's difficult to go through the list of all the 100 subtypes, but the bottom line, and that's why you need expert centers, the bottom line is that if we have seen that doxorubicin, which is our best chemotherapy, is not great, you can imagine that second and subsequent chemotherapies having even less efficacy in terms of response and in terms of progression-free survival and overall survival outcomes. And the selection of the patient so largely depends on the toxicity benefit ratio and depends very much on the histology. Trabectedin is a drug that has been used quite frequently in sarcoma as a second or third line, is given as a 24-hour infusion with a pump, and is particularly effective in liposarcoma, leiomyosarcoma, and synovial sarcoma. gemcitabine-based combination or single agent in leiomyosarcoma and undifferentiated pleomorphic sarcoma, in angiosarcoma as well, and single agent ifosfamide in synovial sarcoma and liposarcoma, and pazopanib, for example, in synovial leiomyosarcoma, solitary fibrous tumor, or ASPS. Again, many of these agents, they provide a benefit in terms of progression-free survival in the range of 3 to 6 months or even less. The benefit on overall survival is more disputed, and this is the reason why, for example, pazopanib is not approved for use in the UK, because the benefit was only in PFS but not in OS. Now, if we go to specific subtypes of sarcomas, we have, fortunately, I would say, some subtypes have specific mutations that can be treated with targeted therapies. And this is, of course, really, really important, because these patients have much better outcomes compared to other soft tissue sarcoma patients. The most important example is GIST, and I will discuss that a little bit more detail. But we have inflammatory myofibroblastic tumor that in 50% of the cases have rearrangements of the ALK genes, and they respond very well to ALK inhibitors. We have pecomas who have mutations in the mTOR pathway in the tuberous sclerosis complex 1-2 genes, and now we have mTOR inhibitors, which are really, really effective in this subset of patients. Desmoid fibromatosis, as previously mentioned, have targeted treatment with gamma secretase inhibitors, even though they respond very well also to low-dose chemotherapy. And as also mentioned, there are NTRK rearranged sarcomas, which are extremely rare, but they respond exceptionally well to NTRK inhibitors. And so these are important subtypes, and this is one of the reasons why, from our perspective, it's really important to have a very precise diagnosis from the baseline. Just saying that this is a sarcoma is not enough, because you have sarcomas which have specific treatment which really have a long-term impact on the prognosis of the patient. Just to give you an example, the median overall survival of a GIST patient in the pre-imatinib area, when doxorubicin was the standard of care, was less than 12 months. The median overall survival of a patient with GIST now is in the range of more than 5 years. So it's important to nail the diagnosis. Emerging treatments, clinical trial, this is of course not a comprehensive list, it's just what is more exciting. And in the differentiated liposarcoma, we have specific amplification where pathognomonic. The MDM2 and CDK4/6 amplifications are the most important. CDK4 and 6 inhibitors alone, they've not proven to be very effective. There is more excitement for the MDM2 inhibitors. A phase 3 trial has been run in the second line, and the drug is being shown to have the same efficacy as trabectedin. Now another MDM2 inhibitor is being tested in first line against doxorubicin. We're waiting the result, and we're excited because this could be the first time in 60 years that a new treatment will be approved for a common sarcoma, and that hopefully will beat doxorubicin. In UPS and myxofibrosarcoma, we know that there is high immune cell infiltration. There have been a number of trials with PD-1, PD-L1, TIGIT inhibitors. Response rates are in the range of 20-25%, which again is not as high compared to other tumor types, but if we compare to the response that we see with doxorubicin and doxyphos, it's not that different. But of course, in terms of tolerability, immunotherapy is much more well tolerated compared to dox. And we know that synovial sarcoma, myxoid liposarcoma, and other sarcomas, they can express specific tumor antigens, and there is a lot of excitement also for the use of CAR-T and bispecific antibodies. These are extremely costly treatments, so they are very exciting from a molecular perspective, from a translational research perspective, but how realistic it is that they will arrive to the clinic is really, really difficult to tell. And there will always need to be that cost to benefit analysis to show that it's really worthwhile doing it. But it's more that once you can develop something that works as a proof of principle, then research will hopefully be increased to develop off-the-shelf products which could be a little bit cheaper. So the take-home message from the advanced setting in terms of systemic therapy is that individual biological and anatomical factors as well patients' preferences should be considered when choosing treatment strategies in the palliative setting. For most sarcoma subtypes, single-agent doxorubicin is the preferred option for disease control when your objective is to increase survival. And doxorubicin-based doublet chemotherapy with ifosfamide or dacarbazine leiomyosarcoma can be considered when tumor shrinkage is what you decide. Second and further lines of chemotherapy are largely histotype specific, and some specific sarcoma subtypes have molecularly driven therapies, and ongoing clinical trials are exploring alternative chemotherapies. So moving to GIST, they're a very common type of sarcoma. They arise from the gastrointestinal tract. They represent less than 0.5% of all GI malignancies. They are more commonly found in the stomach and then followed by the small intestine and the rectum. And they have, as I mentioned, unique biological characteristics and therapeutic options. And they arise from the interstitial cell of Cajal, which has pacemaker activity. Now, GIST represents a paradigm in solid oncology because it was one of the first actually solid cancer with a molecular therapy. And the reason why it's so important because the large majority of GIST patients, they have a specific driver mutation. So in 60 to 70%, this is a mutation in the KIT gene, with exon 11 and exon 9 being the more common primary mutation sites. In 10-15% of the cases, we have mutations in the PDGFR tyrosine kinase, which is closely related to KIT. And then we have the rest of the GIST, which were formerly known as wild-type GIST, but we now know they carry other specific mutations, loss of tumor suppressors like the NF1 or SDH subunits, or activated mutation in BRAF and TRAC. As I mentioned, GIST has been really a prototypical disease, and it's represented also a prototypical disease not only for solid oncology and the use of targeted treatments, but also for what we call translational oncology. The first paper reporting gain-of-function mutation in KIT was in 1998, and the first report of a KIT inhibitor in a GIST patient was published in the New England in 2001. So we went only 3 years took to go from the discovery of the mutation in the disease and the first patient treated with an inhibitor. In that case, we were lucky because there was already an inhibitor which was not specifically designed for GIST, and this is also another lesson that sarcoma doctors are very good at repurposing drugs which have been developed for other conditions. And of course, you all know imatinib, which is an inhibitor not only of KIT, but of BCR-ABL and PDGFR as well, was first used in chronic myeloid leukemia and is very well tolerated. Nausea, diarrhea, fatigue, muscle joint pain, and fluid retention are the most common side effects. And it's really, really important to have the mutational analysis of your GIST patients because, again, treatment very much depends on the mutation that your patient has. There are some imatinib-sensitive mutations, which are the one in the exon 11, partially insensitive mutation, KIT exon 9, and completely insensitive mutations, like the PDGFR A42V and wild-type GIST. So there is no point in treating a patient with imatinib which doesn't have an imatinib-sensitive mutation. Why do we have a difference between KIT exon 9 and KIT exon 11? It's because KIT exon 11 are intracellular in the juxtamembrane domain, which is the region where imatinib binds. So they are really imatinib sensitive, whereas KIT exon 9 are in the extracellular region of the receptor. So the efficacy of imatinib is not as significant. There have been a number of studies comparing two doses of imatinib, 400 milligram and 800 milligram, and the meta-GIST meta-analysis of more than 1,600 patients show that the increase in the dose doesn't have any impact on progression-free survival and overall survival for patients with KIT exon 11 mutations. But if you have a KIT exon 9 mutation, you can actually improve outcomes of your patients. But again, the use of KIT of 800 milligram in KIT exon 9 patients is not uniform across countries. So in many places, these patients are treated with 400 milligrams, But if you have access to 800 milligrams, this could be a very reasonable choice for patients with KIT exon 9 mutations. Despite all the benefits from the treatment with imatinib, we know that resistance is likely to occur with a median progression-free survival of about 2 years. And secondary mutations can be found across the whole gene, but they are more commonly found in exon 13 and 14, and exon 17 and 18. And there is also a change in clearance with chronic dosing. So in some cases, increasing the dose of imatinib can provide further benefit. Imatinib is the most important drug that we have in the treatment of GIST patients, so what we try to do is to maximize its use. So the change to second-line treatment is actually only reserved to patients that have multifocal disease progression. If you have a unifocal disease progression, we really recommend local treatments to try to ablate or get rid of the area of the tumor where we have clones who have developed resistance to the treatment, but then we keep the patient on imatinib for as long as we can. When we have progressive disease, multifocal progressive disease, then is when we consider change of treatment. A very important thing to consider when treating patients with imatinib and other tyrosine kinase is also how we evaluate the radiologic response, because in other tumor type, the evaluation is done with RECIST, which are based on the size of the tumor. But we know very well that the response to tyrosine kinase inhibitors can be non-dimensional in terms of changes in the density of the tumor, and also progression can be non-dimensional. This is the image that was originally reported by Choi, and now these criteria go under her name. This is a pre-treatment liver met from a GIST patient. As you can see, there is a cystic necrotic area, but there is also a very large solid area. 2 months post-treatment, everything has turned to necrotic cystic. But if you only consider the size of the tumor, the metastasis hasn't changed at all. So by RECIST, this is stable. But by Choi, we can say that this is a response because the tumor, the solid elements have actually melt away. And if we look at 24 months post-treatment, we can see here, can you see? Yeah, there is a very tiny solid nodule which is growing in the cystic area. And 3 months after, the solid area is actually grown. But again, if you consider only RECIST, these two scans are stable. But if you consider the non-dimensional component, so the density, you can clearly see that there is a solid component that is growing within a cystic lesion. And this is considered progression. Now, in the second line, sunitinib is recommended. And this is the study by George Demetri and colleagues showing a benefit in terms of progression-free survival and overall survival with sunitinib. But sunitinib is a dirty tyrosine kinase. It has many targets and is not as well tolerated. Pulmonoplantar erythrodysesthesia, hypertension, stomatitis, diarrhea, muscle joint pain are quite common. In the trial, the schedule that was used was the 4 weeks on, 2 weeks off. But we also used the continuous schedule at 37.5 milligrams. This is a very good alternative and is tolerated better by patients. Also for sunitinib, there is a difference in terms of the mutation. We know that patients that have a primary c-KIT mutation, they do not respond as well as patients that have c-KIT mutation in exon 11, do not respond as well as patients with KIT exon 9 mutation. So in this case, it's the other way around. Patients with exon 9 are more sensitive to sunitinib rather than patients with KIT exon 11. In third line, we have regorafenib. Again, impressive benefit in terms of progression-free survival. The benefit in terms of OS is less clear, but this is also approved for use. Again, regorafenib is also quite dirty tyrosine kinase inhibitor with many side effects. And finally, ripretinib is the most recent addition and is a new next generation tyrosine kinase KIT inhibitor with a different mechanism of action compared to the previous one. In terms of side effects, it's very similar to imatinib. So there is a little bit of alopecia, fatigue, fluid retention, but is otherwise very well tolerated. And in the Invictus studies, the ripretinib has been proven to be significantly superior to placebo in both PFS, and this difference is significant, and also in OS. In OS, the difference is not significant, but many patients crossed over during in the trial. So actually, the real magnitude of the difference of the OS is larger. Now, whether ripretinib is going to be approved and used in all the countries is still a matter of debate because the drug is really, really expensive. And for example, in the UK, it's still under review. It's not been approved for use, whereas in other countries, it's approved and reimbursed. As I mentioned, there is a particular subtype of GIST which is imatinib resistant, which is the D842V mutation. And now we have an inhibitor, a specific inhibitor for this mutation, which is avapritinib. And these are the impressive results from the Navigator phase 1 trial. And as you can see, there is a 100% disease control rate, more than 50% of patients having a significant response, and median OS and median PFS, which have not been reached. Avapritinib is also relatively well tolerated. It is characterized by a neurotoxicity, which is quite unique. But again, costs are a problem, and this drug is not approved and reimbursed in many countries because of its costs. But at least in terms of biology and how now we're targeting new mutations is also exciting. And take-home message is that GIST have unique molecular drivers. Activating mutation in GIST and KT is the most common, and we have tyrosine kinase inhibitors. Imatinib at 400 milligrams in the standard of care first-line treatment, although exon 9 GIST may benefit from higher doses. Radiologic response and progression might be non-dimensional, and primary and secondary resistance to imatinib is quite common. Sunitinib, regorafenib, and ripretinib are standard of care in second, third, and fourth-line treatment, and avapritinib has shown activity in PDGFR mutated GIST. Importantly, before we move on to the localized setting, it's important to also mention that there is ongoing research also in the wild-type GIST area. Standard treatments are not very well defined because it's still a little bit unclear, but if you have a GIST with an NTRK mutation, of course, NTRK inhibitors are recommended. If you have a GIST with BRAF mutation, you can request use of BRAF inhibitors. But for SDH deficient GIST and for NF1 associated GIST, we don't really have good systemic treatment options. So in that case, we tend to use more local treatments. If we move to the localized setting, the recommendation is the use of imatinib at 400 milligrams for 3 years. But this is only limited to patients with high risk of recurrence. The use of adjuvant imatinib in patients with intermediate risk is highly debated and is not currently recommended by most guidelines, and only, again, in patients who have imatinib-sensitive mutations. So also in the adjuvant setting, if you have a patient that meets all the criteria of high risk, we do recommend doing the genetic testing, because if you have a patient at high risk of relapse that has a wild-type GIST, there is no benefit in giving adjuvant imatinib. There are a number of nomograms that are used to define risk. The one by Metin and Lasota is one of the most common, and this takes into account size of the tumor, mitotic rate, and tumor location. There also, tumor rupture is one of the other important prognostic elements. The mutation analysis per se is not considered in any of these algorithms to define the risk. But again, if you're thinking about treating a patient in the metastatic, but also in the adjuvant setting, then you have to know whether they carry an imatinib-sensitive mutation. The duration of the treatment is for 3 years, and there is significant benefit both in terms of recurrence-free survival and in terms of overall survival. In the exon 9, the situation is a little bit more debated. We don't have prospective clinical trials specifically for these patients. We've conducted a retrospective analysis, multi-social analysis of patients that have been treated with 400 or 800 milligrams. And in our hands, based on this analysis, there is no difference in the adjuvant setting between 400 and 800 milligrams. So whereas we would recommend using the 800 milligrams in the metastatic setting, in the adjuvant setting, the evidence is not so strong. And if the patient is high risk, it's okay to offer the 400 milligrams. Now, regarding the duration, we mentioned that the standard duration is 3 years, but there are studies showing that investigating whether longer treatment could be also of benefit. And this is a trial that we've run at the Marsden. We've finished the recruitment. It's an international trial comparing imatinib for 5 years versus 3 years in patients at extremely high risk of relapse. Now, as you appreciate, imatinib is not really a cytotoxic because it's not chemotherapy, but it has a cytostatic effect. So the idea of extending the treatment is trying to extend as long as you can this cytostatic effect. But what we really need to see is if there is a difference in overall survival, because it could be that you're extending the relapse-free, but then when the patient relapses, it has already an imatinib insensitive GIST. At that point, you're basically starting second line when the patient is metastatic. So it is true that we have to consider relapse-free, but extending the relapse-free if you're not impacting the OS may not necessarily be the best strategy. And that's why in these adjuvant trials, it's really important to see and show that there is a difference in overall survival. So take-home messages: adjuvant treatment is offered to patients with imatinib-sensitive mutations and high risk of recurrence. 400 milligrams for 3 years is the standard. 800 milligrams does not appear to be beneficial in exon 9. Ongoing studies to test 5 versus 3 years. No standard adjuvant treatment for patients with imatinib-insensitive GIST. Now, after our conversation, I've just added a couple of slides to stir the discussion. Sarcoma are rare cancers, true, but the absolute number is not low. In the UK, we have at least 3,500 cases per year. Considering that the population of Bangladesh will be higher compared to the UK, and also considering the age distribution, and in the Bangladeshi population, there are more younger patients, and the incidence, the relative risk of sarcoma in the younger population is higher. Probably around between 1,700 and 10,000 cases per year. So yes, rare, but still, we think that this population should not be neglected just because they represent 1% of all cancers. Still, a lot of patients. And as we mentioned many times throughout the course of this meeting, the treatment in reference center is associated to longer survival. And this has been definitely and conclusively shown by a number of studies. This is particularly true for surgery, and also for pathological review. So if you have your biopsy reviewed in an expert center, which you can exactly pinpoint the diagnosis, if you have your initial surgery in a reference center, the impact on survival is higher compared to any of the treatments that we have. The receiving also radiotherapy, local treatment, and systemic treatment in sarcoma reference centers or in centers who are connected or linked to sarcoma reference centers has an impact on survival higher than the benefit of the chemotherapy itself in the clinical trials. So in a way, in this case, the structure, the organization, has more impact on survival than the individual treatment per se. And this is, I think, one of the key messages. But it's really easy to talk about reference centers in some countries. Centralization of care requires investments and infrastructures and national support, because you have to actively discourage treatment in small centers. You have to promote and you have to educate. So this is really another key message. It's easy to say, treatment in reference centers, but we should think about how to build these infrastructures and how to push governments to help building these infrastructures. And lastly, prognostic nomograms that I've shown you, the one on GIST, the circulator, as well as all the preclinical cancer models that we use, are really helpful. But it's quite clear that they are significantly biased, and they're poorly representative of different ethnicities and different social situations. And that's why everything that we have developed and in one region, I think they should be also validated in other countries. And I know that there is ongoing work to try to see if the circulator nomogram also has the same power in other ethnicities, and also in preclinical models we're lacking models of different backgrounds. Thank you.